Good evening, everybody. Thank you very much for joining us at this webinar sponsored and supported by Amethyst, who run our Gamma Knife at Queen Square, the National Neurosurgery Hospital. And it's one of the few Gamma Knife services that is supported by NHS England in the country. So we're very lucky, and we've got a large consolidation of talent and knowledge, thankfully, at Queen Square to make it a success. And this evening, we're joined by many people watching who are either involved in making medical and surgical decisions for patients, but also those who are patients and those caring for patients who are also important in understanding what options are available to them and making those decisions. So we've got a variety of talks this evening, which are all a variation on a theme. That's about treating trigeminal neuralgia. We're going to start with Tim Yates. He's a consultant neurologist, and we're lucky to have him. He joined us only in the last year or so, having been spending most of his time elsewhere in London, and he has brought some excellent expertise in particularly facial pain, but also migraine. He's one of the few prescribers of some of the most state-of-the-art migraine medications. His talk is possibly the most important. Lewis Thorne and I are going to talk about treatments for trigeminal neuralgia, but it must be trigeminal neuralgia for our treatments to work. And Dr. Yates is one of the very clever people who put on the Sherlock Holmes hat, whittles down what sort of facial pain this is, because there's so many, and then helps us decide, is this the correct diagnosis? And then he has the role of treating it medically with medication, which is plan A, B, and C in trigeminal neuralgia. We try to do that as much as we can. So welcome. Dr. Yates, take it away.
Thank you for the very kind introduction. Shall we just reset my slides so that we're starting on the first one? Well, this is me. I'm a consultant neurologist with Mr. Hyam and others at the National Hospital, and my disclosures. And this is what I'm going to cover. The nature of the condition, the other things that it can look like, tests that you need to do, perhaps why it happens, and then some treatments which follow from that, and how we also manage when things are going badly wrong. So trigeminal neuralgia is the most common cranial neuralgia. That's to say a disorder where the predominant pain is recurrent, short-lived paroxysms, which are shooting or stabbing normally, limited to the distribution of one or more of the sensory divisions of the trigeminal nerve. And the nerve supplies the face as shown, but also the sensation in the mouth and tongue, where pain can also be felt. And it's a rare condition. The average number of patients registered to a GP practice in the UK is under 10,000. So this really is only one case every 2 or so years in each GP surgery, if it's recognised at all. It's more common in women, but is still prevalent in men. And the mean age of onset is in the 50s, although it can really arise at any stage. As mentioned, the severe, brief or stabbing paroxysmal pains are limited to the distribution of the trigeminal nerve. The diagnostic criteria require the pain to be on one side of the face only. It's usually triggered, and attacks will last less than 2 minutes before remitting entirely back to being pain-free. There are usually no so-called cranial autonomic features involved, like tearing or eyelid droop. And TN is subclassified on the basis of a scan and sometimes further testing. Now, classical TN is where there's definite neurovascular conflict, i.e. a blood vessel is interfering with the trigeminal nerve. In secondary TN, there's an underlying disease process, and in idiopathic TN, the tests are normal. And while the bulk of TN is purely paroxysmal, it comes and goes, there are patients with continuous background pain and flares on top, but that usually develops later. The key test is an MRI brain with trigeminal sequences, because a standard MRI doesn't look adequately at the nerve itself. And with the results of such a scan, TN breaks down like this. About 3/4 of cases are expected to be classical, with a finding of neurovascular conflict on the scan, and the remainder are split between secondary and idiopathic causes. The expectation is that TN is strictly unilateral and always on the same side, but about 3% of patients with this rare condition do develop pain at some stage that may affect either side, and it should not necessarily put you off as long as the remainder of the phenotype is consistent. One would not really expect simultaneous bilateral pain, tends to be one side and then the other. Studies of most common branches of the trigeminal that are involved consistently show that only 3 to 5% of patients have pain up on the forehead, just limited to that. Where the pain is predominantly there, I think of sooner or sunct first, which are alternative diagnoses. The pain in TN is typically in the cheek and in the mandible, sort of V2, V3, or both. And TN is almost always triggered, so it's worth exploring that with patients. A minority only have spontaneous attacks. Characteristic triggers include eating and brushing the teeth, and the most common extraoral trigger zone is around the nose and around the mouth, with touch, talking, or cold wind being triggers that are commonly mentioned. What can TN be confused with? Well, the differentials for it are those causes of somewhat neuralgiform pain involving the face. Glossopharyngeal neuralgia is usually restricted to the back of the mouth, the posterior oropharynx, but can spread onto the face. Nervus intermedius neuralgia is deep in the ear, but can affect the area around the mastoid, the soft palate, and the angle of the jaw. The trigeminal autonomic cephalalgias or attacks are rare headache conditions, and they're worth thinking about, particularly the neuralgiform sunct and sooner attacks, which can overlap with TN and are felt in the forehead typically. Likewise, other attacks, though longer lasting, can involve superimposed stabbing attacks, as can facial migraine, which is probably the most common cause of neurological facial pain. Neuropathic disorders are usually reasonably easy to differentiate, as the predominant pain is not paroxysmal but continuous to some extent, and sometimes a cause can be identified in the history. Very often one should involve specialist dentists or maxfacs in atypical cases to look for oral causes like cracked tooth syndrome. And there are also serious causes to rule out with a scan like MS and tumour. So all patients with suspected TN should have appropriate imaging, which means an MRI head with dedicated trigeminal fine cuts. As I said, this helps subclassify the disorder. And also because we're likely to consider particular types of surgical intervention depending on what that scan shows. But a scan neither diagnoses or rules out TN, which is a clinical diagnosis, i.e. one made by talking with the patient. This is because studies reveal that very often there's neurovascular conflict in patients without any history of TN, or patients may have trigeminal neuropathy, and it's very frequently found in other conditions like sunct and sooner. And sometimes the conflict is found on the opposite side to the patient's pain. So while a scan is not a substitute for good clinical phenotyping, it is definitely important in planning future treatment. And different theories exist for the cause of the pain. The peripheral theory suggests that local damage and so-called demyelination of the nerve allows spontaneous firing of the nerve, which can reach a threshold for pain, or that because the myelin's broken down to some extent, there can be crosstalk between those nerves and cross-fascicle activation, which allows a threshold to be reached again for an innocuous stimuli to be perceived as pain. And the central theory suggests that the change can occur in the brainstem, reducing the ability of the so-called wide dynamic range neurons to gate stimuli and mark them as non-painful. A further small study suggests that injuries to the myelin affect the balance between two important variants of the voltage-gated sodium channel, which tends to make the nerve more easily excitable, so that innocuous stimuli are felt as severe pains. This latter idea justifies our drug treatment choices, as many of these agents have actions at the sodium channel itself. These drugs are chosen to be taken medium to long term to damp down and abolish pain. They are preventative treatments, and they're usually tried in a sequence something like this, which reflects the evidence and tolerability, but we also take into account patient preference and any other relevant medical conditions which might make a particular drug a better choice because it treats something else as well, or a worse choice because of something else the patient has. They work best for the symptoms of paroxysms of pain, though, and they're less good for continuous pain or sensory symptoms. So starting with carbamazepine, or the better tolerated oxcarbazepine, most neurologists in the field would then move down this list. We would start a drug, slowly increase it to improve tolerability, and then go as high as we can with the dose. If this is effective, it's continued or optimized, and if it's not effective or if side effects arise, the medication is weaned off and the next started in the same way until something satisfactory is found. Through life, the burden of TN can wax and wane, and patients may be able to wean these medicines substantially or completely at times, but at other times may need higher doses for a period, and they should be given the latitude to do so by their doctors. Botox is something extensively used to treat migraine, and work is going on to look at the use of Botox in TN. There are only a few older studies thus far, and it's so generally not considered an option for treatment on the NHS. My view is that the evidence is very encouraging, and this is likely to emerge as a treatment option in specialist hands, particularly as progress is being made with approaches to reduce the poor cosmetic outcomes that have been associated with the treatment in the past. It's something for the future for those with TN refractory to medication or where surgery is not appropriate. The evidence supports this algorithm. For secondary TN, you treat the cause first, the tumour or whatever. For classical or idiopathic TN, at least 3 trials of medicines are first made before considering surgical intervention. And you'll see that Botox is currently not featured as an option. Despite good preventative treatment, and particularly for those that cannot find a good preventative, sometimes the pain can worsen and get out of control. And this means that eating and even drinking can be difficult, and a variety of approaches have been tried to try and control that worsening. There is evidence for local anaesthetic if trigger points are a particular problem. This can be rubbed into the oral mucosa or into the trigger zone elsewhere. It can be sprayed nasally, sometimes offering benefit for a few hours. Targeted nerve blocks at the trigger points have been used. These are a bit more invasive and cannot be self-administered by patients, of course. I tend to think that the benefit is usually shorter than quoted in the studies, but I think it's a useful add-on. IV phenytoin is fairly widely available even in A&E because it's a standard treatment for epilepsy and is often helpful. IV lidocaine can be helpful, but there's less experience with it, so it tends to be used in more specialist pain services only. I would typically start with phenytoin. What else? Well, sumatriptan injections are used in migraine and cluster headache, but are also worth trying in a flare-up of TN pain, particularly if there is no particular trigger area to target with something else, and I do recommend that. Again, it's a treatment that can be used, can be under a patient's control, so they don't have to seek help from a hospital or specialist if they're getting into trouble. This then is my flowchart for acute exacerbations. Try a local anaesthetic or triptan, depending on whether there's a trigger area, and if there's no improvement, commence an infusion of something like phenytoin and lidocaine. And of course, preventative treatment drugs like the carbamazepine and other things we've mentioned should be optimized. So in summary, TN is a clinical diagnosis. A scan is useful not for diagnosis, but to categorize the condition into classical, secondary, or idiopathic conditions. The treatment is typically with preventative drugs, and a patient may unfortunately need to work through several before they find one that really suits them. But overall, if more than 3 are unsuitable, seeing a neurosurgeon is an option, and Botox may be a more mainstream option in future, but it's early days. Despite good treatment, TN can sometimes flare, which is awful and can prevent eating and drinking, so patients should really have some idea how to treat such flares and have access to their specialists in time of difficulty. Thanks very much.
Thank you for that very authoritative talk, Dr. Yates. I'm sure that's prompted lots of questions. There is a comment column on the right side of your screens at home. So if you do have any questions, please propagate them in there and we'll go through them at the end in the question and answer session. So moving on to Gamma Knife specifically for trigeminal neuralgia. The most important thing is that the diagnosis is neuralgia. We'll talk a lot about trigeminal neuralgia, and we'll also look at glossopharyngeal neuralgia, another one of these paroxysmal facial pains where Gamma Knife can work. Very importantly, there are diagnoses such as atypical facial pain or trigeminal neuropathy, where there's constant unremitting pain. It doesn't go away. It feels like gnawing and dragging rather than the usual electric shocks that appear and disappear. So for those gnawing, dragging, constant pains, unfortunately, Gamma Knife isn't a good choice for the atypical or the trigeminal neuropathies. So that's probably the most important point to get over. For neuralgia itself, it can be a very successful treatment. So what does this word stereotactic mean? It just means precisely targeting instruments or radiation in three-dimensional space. And because the brain has so much important clockwork that you don't want to be interfering in, you need to be very specific about where you can target that. And Sir Victor Horsley, after whom the department is named after, Queen Victoria's godson, was one of the pioneers of minimal access brain surgery. And his counterparts in America were the pioneers of operating on the brain and stopping all this terrible bleeding using instruments such as bipolar that we see. And all of these is focused down into what we have for modern neurosurgery. And what we use on the head is a frame. So the late Professor Aziz from Oxford is modelling it here at the Science Museum on the right side. And it's a real objet d'art. So that was the original frame. And that gives you coordinates of every single point inside the brain. So that can be boiled down to an X, Y, and Z. So you can be extremely accurate when you're targeting. This was taken to the next level by Lars Leksell in Sweden, who pioneered the Leksell gamma knife, as its full name is. And he performed biopsies and treatments using a frame on the head that could be very accurate. And he felt that instruments are one thing, but actually if you can treat the brain without actually having to open the scalp or open the skull, or pass and cross brain tissue that you don't need to, all the better. He developed a new form of frame, which is still a variation on the theme, called the Leksell frame, which is quite helpful for neurosurgeons because it boils everything down to just an X, Y, and Z coordinate. So with a scan and a ruler and a pencil, you can work out coordinates without having to just rely on computers. Unfortunately for Leksell, imaging wasn't always like this. He usually had to rely on X-rays. CTs were only brought in the late 70s, MRIs in the 80s. So he predated that in the 50s and 60s. So stereotactic radiosurgery. So radiosurgery is not really surgery. It's performed by a surgeon mostly for the head. But the radiation is delivered in a surgical fashion, i.e. precise, rather than a diffuse wave. So this is the first stereotactic radiosurgery trial. So this is for treating arteriovenous malformation. So the frame is on the patient's head, and this one source was used. So you see what looks like a periscope going to the patient's head. So that is the one trajectory where the treatment's going to be given. Leksell further refined it to make multiple trajectories. So you see what looks like a big colander on this lady's head. Lots of holes and lots of different sources of radiation. And this is the first gamma knife. So all those beams are coming in from different angles simultaneously. They're all innocuous. So we're all receiving gamma radiation since the Big Bang going through us. You don't feel it, it doesn't do any harm. Here, from the cobalt-60 sources, these innocuous rays converge and cross over, and it's at the point they cross over they give a hard toxic dose. So unlike whole brain radiotherapy, where you have an entire noxious wave of radiotherapy through the whole brain, with this, the actual toxic part is confined into a very small volume of tissue. In this way, you can shield important brain structures. So if we look at the graph at the bottom right, at the top of the peak is where the shot will be focused. And by a couple of millimeters either side, it's almost zero. So this is the drop down in exposure to surrounding brain that you can protect it by giving treatment. So this is one of the frames we use, one of the Leksell frames. And this is the uncomfortable part of the day. So we give local anesthetic, 2 in the forehead and 2 at the back of the head. So if anyone's ever had local anesthetic, it's a needle that pierces the skin, and then there is what feels like acid as the local anesthetic takes effect, and then it goes numb. And then we put the pins on. They've got to be quite hard. They've got to push the skin onto the bone. They don't go through either of them. They've got to push on hard because you don't want the frame slipping around and you're shooting the wrong part of the brain. So that's the uncomfortable part of the day, but most people tolerate it fine. And then that frame stays on for an MRI scan and then through to the end of treatment, after which we take it off. So the gamma knife procedure is effectively an outpatient procedure. You don't need to change your clothes when you come for it. We don't change our clothes beyond our usual medical attire. And most treatments for trigeminal neuralgia, we are completed by lunchtime, by which time you can go home. And we use local anesthetic for the frame. And when you're actually receiving the gamma radiation, so this is a lady lying on the couch about to receive it, you don't actually feel the rays, you don't hear anything, you don't see anything. Most people just go to sleep or listen to their favorite radio station or music. So the gamma knife has evolved over the years. In the early 2000s, Electa asked all the practitioners, what would be your ideal? And one of the major preferences was removing as much human error as possible. So the gantry that moves the patient into different positions to receive the treatment, that's all now robotized. So it's a robotic gantry that moves independently of us, and we tell it where we want to target, and it moves the gantry in the patient's head to deliver that. So this was, at the bottom right, the initial installation of our gamma knife by our head of gamma knife, Neil Kitchen. And the current iteration is the icon, which is at the top left. And it's fundamentally the same as the original, but it has that robotized gantry. We also have that arm that you can see on the left side, which is a CT, which can help us with registration, fine tuning. So trigeminal neuralgia. We've heard all about the neurovascular conflict. Lewis Thorne's going to be much more thorough looking at this in a few moments. When you do have neurovascular conflict, the closest to a cure and the best outcomes when audited several years later is the operation, if you're fit for it, the microvascular decompression. If you're not fit for it, or as in 50% of people approximately with trigeminal neuralgia don't actually have a blood vessel pushing on the nerve, then you have to think of alternatives. And gamma knife is a very, very good alternative. So the gamma knife practice over the decades is very much focused on benign tumours like meningioma and schwannoma, and lots of these happen at the base of the skull. And at the bottom left of the screen, you can see a vestibular schwannoma, so something growing on the balance nerve, and the gamma radiation tunes to treat it. It's therefore an area where gamma knife practitioners are very used to working and targeting. And just next to that balance nerve is the trigeminal nerve. It's a centimetre or two up, and you can see it on the bigger picture. And you can see there the concentric circles, and the yellow is 50% of the dose, and the green is 20%. So by the time you've got to the green, you're delivering only 20% of the dose to surrounding structures, and it's the dot in the middle where you're giving the full dose. So you're really pushing everything toxically into the nerve with very little fallout to surrounding brain. So initially, when gamma knife was put forward for treating trigeminal neuralgia, it was for those who weren't fit for surgery or other invasive treatment. They balked at the idea of having brain surgery, didn't want invasive treatment, or they were taking blood thinners. We do have to stop blood thinners for a period if we do any invasive intracranial treatments. So if people are on blood thinners for heart valves or repeated clots in the lungs, then that is quite a risk if you stop those. So gamma knife appeals to that need. So what does it do for people? So it reduces the severity, it reduces the frequency. It's very good at reducing the bang, 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 bang. Constant pain, constant burning, it's not good at improving. And the triggers are the other aspects. So the cold air, the touch, the chewing, these are also improved. So if we look at the outcomes of trigeminal neuralgia, so this is 20 years ago in 2005, so the initial groups going through. And at 16 months on average was the follow-up. And 30% didn't have a success. They had a failed treatment. They didn't get significant improvement. But 40% had complete pain relief, and 25% had very satisfactory pain relief. So it's not 100% treatment. There are failures. But for a morning where the brain is not directly open, the skull is not open, and the scalp is not opened, the low risk profile is quite a good option. And that was 20 years ago. So we've revised our targeting, and things have evolved, and we aim for slightly better results than that now. Such was the evidence in the last 15 or so years that NICE have been supporting the use of gamma knife for trigeminal neuralgia. And although the results can be variable, 9 out of 10% of patients can say they had some or good benefit. And if we look at when that occurs, the most important aspect of treating a what we call an ictus, someone's in extremis, a terrible episode of trigeminal neuralgia that Dr. Yates mentioned, that's primarily medical, and we wouldn't use gamma knife. Lewis Thorne will talk about some of the treatments through the base of the skull that can be very helpful for that. And the reason why I wouldn't treat gamma knife for an acute flare-up is that it takes a while to kick in. It's a gentle treatment, but then the effect takes a while to gently improve. So if we look at this graph here, it was really by 1 to 2 months that people were noticing the improvement, and it's really by 6 months that you're getting full effect. So I advise people not to stop or drop their medications for a good 2 or 3 months afterwards, because if they have the flare-up and gamma knife hasn't started yet working, then it's a problem. So the incidence has increased and increased, and these are the numbers just back to 2008, after which it's gone up exponentially. So what does it do? So it partly injures the nerve. So we see at the top the nerve prior to gamma knife treatment. So this is looking at the water molecules moving along the nerve on an MRI. Then at the bottom, you've got a hard stop in certain pathways in the nerve where there is injury to those axons, and they're not conveying information to the brain that someone's stabbing you in the face when they're not. So it's changing the axons within the nerve over a period of time. This can lead to numbness. So this is something else important to talk about. What is the downside of radiosurgery? It's very unusual, pardon me. It's very unusual to cause a major problem for somebody. A stroke or risk to life doesn't happen. However, the risk that we do worry about is causing painful facial numbness. And that's, remarkably, some people say is worse than the actual neuralgia they started with. So the patients who already have deep numbness in the face, we worry about putting them through gamma knife. So that is an important aspect of the preoperative screening. The numbers of that is low, a few percent. So it doesn't stop us in most cases progressing to that, but that's one of the small risks. If we have a look at the outcomes, and this is the team from Flickinger in Pittsburgh, and their outcomes actually pretty good. So at 5 years, 54% of people were happy. At 3 years, 73%. So, compared to open head surgery, something which doesn't have a risk to life or stroke is a pretty good option for people. Can we do it again? Yeah, we can repeat gamma knife. So if we look at a systematic review, sorry, lubricating my throat after a long day of clinic. Patients who have had a recurrence of trigeminal neuralgia, we can retreat. If it's worked for less than 6 months, we tend not to, because it implies that they're a non-responder. More than that, then we'd be happy to take it on. But there is an importantly slight increased risk of making any facial numbness worse. Apart from that, it's the same risk as before. If you've had gamma knife, it doesn't stop you having the other treatments. Sometimes when there is a recurrence, patients went on to a different sort of treatment, such as the surgery or the radiofrequency or glycerol that Lewis will talk about in a bit. This was the algorithm put forward by the Marseille group. So on the top, if there is neurovascular compression, we recommend you have the surgery. If there isn't, or if there's multiple sclerosis, then we think more about gamma knife. If there is dreadful pain, then the quickest to improve that is what Lewis will talk about, which is injection through the face. Glossopharyngeal neuralgia. So that is similar to trigeminal neuralgia, but it happens in the throat and in the whole of the ear. And we've had promising results with treating that. Still about 9 patients. We've had 2 non-responders. One who had a recurrence and successfully was retreated, and the others have done very well with no adverse effects at all. You can alternatively operate, but there's a lot of important clockwork around the glossopharyngeal nerve, such as the vagus nerve, which is important for heart rate, gut motility, and the things we don't think about day in, day out. And we give a similar dose as we do in trigeminal neuralgia. And the risk retreatment, there's been some documented numbness at the back of the throat. Primary treatments, there have been no adverse effects at all. So this is Gamma Knife for trigeminal neuralgia and glossopharyngeal neuralgia. The most important things to take home are it doesn't work, unfortunately, for atypical facial pain or trigeminal neuropathy. There's a low-risk alternative. And that leads us on to the other alternative treatments that we can offer people surgically, and that will be Lewis Thorne, my colleague. So Lewis has a couple of decades of experience treating trigeminal neuralgia, has huge experience, and he forms one of our nucleus of surgeons at Queen Square who can deliver all of these treatments. So take it away, Lewis.
Thank you, Johnny. So yeah, there's a range of interventions that you can do for trigeminal neuralgia, and you can generalize about what applies to which individual, but it is very much a case of matching the treatment to the patient rather than saying there is one perfect treatment. And I think that's why I have a range of the different things that I can do, and very much Gamma Knife being one of them. And to sort of understand how to apply them, it's helpful to know a bit about how they were discovered and how they found their niche. But in the generality, as Tim was alluding, there's something in the condition that means that the nerve is acting like an amplifier. So effectively, touch becomes pain. And so in treatment, you can either try and turn the amplifier off, or you can try and turn it down. And that's effectively what medication is doing. It's reducing the amount of activity within the nerve in some manner. And you can do that to the nerve with some kind of surgical intervention. So looking at the history. So I mean, the first descriptions of neuralgia go back hundreds of years, and there's no reason to think it's a new disease. And people have tried all manner of things. I won't read them all out, but it's interesting to look through and see what's been done. And at first they seem kind of crazy, and some of them are. So I think immersing the hand in painfully hot water probably isn't likely to work. But some of them stand out, possibly because they would effectively treat trigeminal mimics, and some of them because they were particularly likely to work. And the ones that stand out to me here are topical applications to the face of tar, ice, and vibration. And these are all going to achieve the same thing, which is an injury to the nerve. So if you want to reduce the speed of transmission in a nerve, stop signals getting back, if you injure it, that's what you will achieve. Now, all the things I'm going to describe in the first part are what are charmingly called destructive therapies. They all work by deliberately injuring the nerve. They all, therefore, have the same potential problems. Number one is numbness, which is variable, usually mild, usually self-limiting. But it's not for me to decide what's mild and how long counts as self-limiting, because it can be very numb, like you've been to the dentist, and it might persist a week or 2 weeks. But if at 6 weeks you're still spilling soup and biting your tongue, biting your cheek, that's pretty wearing. That's unusual with any of these procedures, but can happen. Then there's the concern about too much injury to the nerve, and Johnny mentioned about this. This is this thing, anesthesia dolorosa, which is a painful burning numbness. And this is the main limiting factor when considering these treatments. Is there's the interventional risk, the risk of doing something surgical, so that means bleeding, infection, all of which can happen, but is pretty predictable and rare. Anesthesia dolorosa is equally rare, but harder to predict, other than to say it's very unlikely in somebody with classic neuralgia having their first treatment. It becomes more probable the less classical the neuralgia, or the more evidence they have of existing nerve injury from previous treatments. Because if you injure the nerve to affect a treatment, it will, to extent, unfortunately recover, and the pain will come back. And so all these procedures should be considered as temporary. The pain will probably come back and may need to be repeated. That said, probably just under half of people who've had one procedure go on to have a second one. Most will be managed medically after that event, even though the pain may have come back. So if we go into this a little bit more. So the big change happened a couple of 100 years ago when there was an anatomical understanding of the difference between the facial nerve that moves the face and the trigeminal nerve that reports back sensation from the face. Because people had realized that some kind of destructive injury could reduce the pain, but it was also causing problems of facial function because people were somewhat indiscriminate in what to treat. And it started to become more rational as time moved on, and people would do something noxious to the nerve at the points where the nerve was coming out in the face. So this is in the chin, in the cheek, and just above the eye. And you can still do these procedures. I've still done them on occasion when need required. You can cut the nerve, you can avulse it, and you will produce numbness, but you can effectively reduce pain transmission in a fairly, in terms of surgical risk, very low risk procedure. But the concern with causing a deliberate destructive injury about this is whether you're going to cause a painful numbness. And this evolved into percutaneous procedures. So rather than cutting the skin and grabbing the nerve, instilling noxious chemicals, usually alcohol. And this is something I have done once or twice under particular circumstances, and actually found it to be fairly effective, but it doesn't tend to be very long lasting. But for someone who needs a procedure and can't really tolerate much in the way of surgical intervention, it can be done. What became clear as time moved on is that the further upstream you did your intervention to the nerve, the more effective and long lasting it was. And our father of British neurosurgery, Victor Horsley, would go around to people's townhouses and on the kitchen table perform a craniectomy, lift up the floor of the skull and find the nerve, and then sort of squeeze it with his finger. Other people did things like drip in hot wax or petroleum, you name it, it was tried. And although this sounds extraordinarily drastic, you have to remember that there was no other treatment at the time. And so people put up with the high morbidity and sadly the high mortality as well, because the one thing it did do as an operation was work. And that was refined as the centuries moved on. And the sort of standard treatment after a while, popularized across in America, was to do an opening at the back of the head and look down between the skull and the brain and see the nerve and actually cut the nerve just as it was entering the brain. And that's trigeminal root sectioning, which was being done still as I entered my training, although that was the end of last century, so it was a long time ago. But another way was found of reaching a similar destination, and this was brought about by a German surgeon who is a maxillofacial surgeon looking to perform local anesthesia to the face, and he wanted a way of targeting the whole of a trigeminal nerve to inject local anesthesia. And the trigeminal ganglion sits just above a hole in the bottom of the skull called the foramen ovale, which the trigeminal roots descend through. And you can target that by putting a needle next to the mouth and guiding it subcutaneously to the floor of the skull. And you put a finger in the mouth so you can feel that the needle hasn't come into the mouth and gone back it again and taken up oral flora. And then when it's in there, if you inject local anesthesia, you'll get complete numbness of the face. I've looked into doing this to use it as a testing procedure, and you can only find this in really old textbooks. And they all cover the same advice, which is first get your crash trolley. So I haven't done that because injecting local anesthesia into the CSF around the brain is a bad idea. But people discovered that with the needle next to the trigeminal ganglion, you could put all manner of noxious things in. and they would prove effective, similar to Victor's open surgery. And again, weird things like phenol, alcohol, wax, but they worked. If too much went too far, it would spill over and affect the facial nerve, causing facial paralysis. And because it caused a lot of numbness, people would often have a numb eye. And they wouldn't be aware if a foreign object got into their eye or scratched their cornea, then they get infections, and people would lose their vision from secondary corneal abrasions because they just weren't feeling them. But that Hartle approach and the understanding of nerve injury led us to the modern era of these needle-based procedures, one of which was a side product of gamma knife treatment. Lexell wanted to do gamma knife treatment, but didn't have a way of targeting the ganglion because there was no scans in the 50s when he was trying to do this. 70s, sorry. And he got one of his trainees to do the Hartle approach and to inject tantalum dust, which would then show on an X-ray. But they needed a vehicle to inject the tantalum dust in, and they just chose as an inert material glycerol. And that was fantastically successful at depositing tantalum dust into the ganglion. But then none of the patients went on to have gamma knife because all of them had pain relief. And that was the birth of glycerol rhizotomy. And it has been used, still is used up into the present, but not in the UK. And that's only because there is no current source of pharmaceutical grade glycerol in the UK, and hopefully that will be resolved fairly soon. And people even carried on using tantalum for quite a while afterwards until it's realized that glycerol was the effective agent. And like most things in medicine, we don't know how it works. A similar procedure is to put a needle in and to use high frequency electrical current, which heats the tip of the needle to heat the nerve and selectively injure the pain fibers. The advantage of this is, Tim was pointing out that most people have it in the third or second and third or just the second. You want to avoid numbness in the eye. So if you put the needle in when the patient is asleep and then wake them up, you can put a test stimulation down the needle. The patient will tell you exactly where they're feeling that. And if it's in the same position as their pain, then you put them back asleep again, you crack up the voltage, and that will heat the nerve. And similar again, but different, is to inflate a tiny balloon in that location. And that's balloon compression. All of these I do, and I would say that there is no difference between them. There are no head-to-head studies, but if you look at large trials of individual techniques, they all come out with the same sorts of results. They last around 2.5 years on average. I've seen some that have lasted weeks and some that have lasted many more years than that. But it's not specific to any one procedure. But if a patient has got multiple triggers or multiple divisions, then a balloon or glycerol makes sense. If they have got a very defined trigger, that's a classic there, then a V2 thermocoagulation is very effective. Or if you've tried one and it didn't work very well, you'd probably try a different one the next time around. But they're quick procedures, and they can be done usually at quite short notice. For someone who's an extremist, can't eat, drink, isn't responding to medication, you can just fix them, boom, in an instant. And I'll bring people in as an emergency if that's what's required to do it. I'll quickly mention about the other surgery. So this is the Hartle trajectory, showing you how it goes straight to where the nerve is. But I'll just quickly mention about the non-destructive treatment, which is microvascular decompression. And there's a guy called Janetta in the 60s, and the more you read about American surgery, the more you understand about why they pay so much in indemnity. He did a lot of nerve root sections for neuralgia, and he thought, you know, every time I do this, I see there's a big artery squeezing the nerve. So one day, instead of cutting the nerve as he had promised the patient, without any consent, he separated the two. But luckily, the patient was completely pain-free. And that gave rise to this operation of microvascular decompression, which has now completely supplanted the idea of doing a nerve section. What you do is make a little hole in the back of the skull, based on the confluence of the sinuses, the transverse sinus is turning into the sigmoid sinus. That takes you as far lateral as you can go. And schematically, you're looking down the wall of the skull, the tentorium above, and in real life, it looks just like that. So that's the side of the skull, tentorium there. It's hard to appreciate, but that's a trigeminal nerve. And that is an artery tucked into, and it's usually tucked into the armpit of the nerve. And it's not just compressive, but it's bound down by a cobweb of what's called arachnoid membrane. And if you take time to dissect away the membrane, you actually now can push this artery up. So that was poking down there on the other side. It's now pushed up on top of the nerve, and now it's completely pushed away, and then it's glued in place. So we're trying to avoid what people used to do, is putting a wedge or something between nerve and vessel. We just want it completely away, so you just got the nerve hanging there in the air. So I'll leave it at that point. So the great advantage of the microvascular decompression is it's the one thing that really lasts, but it's not for everyone. It's not something I would do in an emergency unless it's something that we'd agreed a long time in advance that we could do in an emergency. And it's not for everyone, either by choice or by whether they may not have a crossing vessel, or they may not be otherwise well enough to undergo such a procedure. So to summarize, there are lots of procedures. There is no perfect one, but there's usually one that's well suited to an individual patient. Thank you.
Super. Thanks for that, Lewis. Real masterclass of neurosurgical history, and shows how we've ended up where we are, often by serendipity. We're going to move on to our next speaker, and thank you so much, Aneeta Prem, MBE, for speaking and being with us today as part of the Trigeminal Neuralgia Association. So Aneeta received her MBE for work in charity, and she's been a real dynamo at the Trigeminal Neuralgia Association. And for those who don't know it, it's very much a patient and their carers association. If anyone's doing any sponsored bike rides or marathons, please bear her in mind. Take it away, Aneeta.
Thank you. Thank you very much indeed for inviting me this evening. And I think one of the key things that comes across is that so many patients, when they come to see you, will be absolutely desperate, and they will describe it as the worst pain known to man, and they've come and maybe had a look at Google and seen some shocking headlines about what the pain is called. But at the charity, one of the key things we do is offer support and help, not only for the patient, but also for their extended family and loved ones. Because when you have a diagnosis, and the GP may have taken years to find out you've got TN, you may have had several teeth taken out, all in the process of finding out that finally you get to see your neurologist, who's going to be excellent and tell you that you have TN. They've ordered some scans for you. You're probably quite a long way down the road, and you've tried various medications. So as a charity, what we have, and I'm really proud of, is a helpline. And for the professionals out there, you can refer your patients to this. This is a free phone helpline, and it's a lifeline. It's manned by volunteers 7 days a week, 365 days of the year. And everyone on that helpline has personal experience or knows of someone that has TN, and they've all had quite extensive training, not only on trigeminal neuralgia, but other types of facial pain. And they offer, we have many people that come to us that are contemplating taking their own life. And that's how serious this is. So it's really important that in between appointments, when they feel really lost, when they've just had the diagnosis, that they have got somewhere to go. And the other thing that the charity does is recognise that there is a huge amount of loneliness, isolation, and a lot of mental health that also is running alongside having chronic pain. And for that, we hold regional support meetings. Since COVID, many have still remained online, but we now have a large number throughout the whole of the United Kingdom of face-to-face meetings. And we have experts in the field that come to that, and they speak to our groups, up to about 30, 40 people per regional support. And they're really well supported, and people feel when they come away that they're listened to. And for many, it's the first time they've ever spoken to anybody with TN. And I know when I sit in waiting rooms as a patient who has trigeminal neuralgia bilaterally, I spend a great deal of time in waiting rooms, but I do talk to other patients and let them know what's available to them. The other thing the charity does is have national webinars, and we're really lucky to have an excellent medical board that has Jonathan on it, as well as Giorgio Lambu and Sinan Barazi. And we have some, the world's experts, I would say, that are advising us and helping the charity move forward. In terms of the numbers, we have 2,000 members at TNA UK, which is quite a large number of paid members, but we also have about another 3,000 that are on our mailing list. So we have a very large reach of people that we can speak to and that we can share information of trials, of best practice, and what hope is available to us. We also have a national meeting. If we can afford to do that, we hold that annually, and we've done our last one in Cardiff, and it's been exceptionally well received. And I think for us, the other part of what we do is there's active liaison between not only what the charity does, but I speak very often to health ministers, I speak to government, I speak to the NHS, I speak to prescribers about exactly what TN. And we're struggling a little bit, but we're trying to speak to dentists because often that's the first place where patients are diagnosed. But if someone has trigeminal neuralgia, we always say you're not alone. There's somebody at the end of the phone. There's someone that will speak to you. There's someone that can help you through what you're going through. And we can obviously refer to the very best possible help and advice out there. Thank you.
Thank you very much, Aneeta. And thank you for your sterling work for these sufferers. This is now the question and answer session. So we'll bring back the rest of the faculty. One popular question is, how do we obtain the video? It's going to go on the Amethyst Healthcare YouTube channel first, which I think will be tonight, if not tomorrow. So that's definitely going to be available to all of you shortly. If we go on to the next question, this is probably one I'll direct to Dr. Yates. How long should patients remain on first-line medications such as carbamazepine or oxcarbazepine before considering alternative treatments?
So when I'm answering this question, I'm assuming that the patient has reached a high enough dose, which is generally going to be the highest dose of these medicines. So for carbamazepine, is going to be perhaps more than a gram a day, if tolerated. So you find the maximum dose that you can take, and then you need to stay on it for 2 to 4 weeks. And that can be a period that's quite torturesome, unfortunately. But the beneficial effects can take that long to kick in. But I think if you wait for longer than 4 weeks at a suitable target dose and you've not had any benefit out of it, you quite quickly need to move on to something else. And certainly when I'm giving plans to patients, I try and say, well, it's this and then it's this, so that they can move on to the next one as soon as possible.
This brings up another aspect as to how someone ends up on a surgical waiting list, and they've usually either had intolerable side effects from medications, or they've tried 3 or more medications without controlling their trigeminal neuralgia. Okay, if you move on to the next question. So I might take that one. What about tapering medications after surgery or other treatment? Well, gamma knife is probably the exception to the surgical procedures in that it doesn't work immediately. So we don't taper the medication immediately. We usually wait for 2 or 3 months, then ask the neurologist to taper them down. I think when Lewis Thorne does a radiofrequency percutaneous procedure, you can correct me, Lewis, but it's instantly helpful, so you can taper down quite quickly.
It's nearly always it works straight away. Occasionally it takes a couple of weeks. If you're very unlucky, it gets worse before it gets better. So I usually tell people to stay on what they're on for 2 weeks, and then if they're happy with the results, then we'll guide them through coming down slowly. And being guided is really important. Some patients are very tempted just to stop because the pain is gone, but I've seen people run into real trouble with withdrawal from things like carbamazepine.
Okay, so next question. So we've got two questions about CyberKnife. Does anyone want to take that, or shall I?
Well, I've trained in both Gamma Knife and CyberKnife, and the main reason that I use Gamma Knife is it's much closer to me than the CyberKnife that was available to me, which is a fair mile away. But that's not the real reason I choose between them. I think if you were having to buy a stereotactic radiotherapy machine for a wide range of uses, I would buy a CyberKnife. But if you're looking for specific cranial uses, my own feeling is that the accuracy is probably going to be better with a frame-based system, which the Gamma Knife is. But there is data out there from CyberKnife, and people have had good and equivalent results. So it's Gamma Knife it's like the difference in a vacuum cleaner and a Hoover. We're describing different trade names for similar technologies. So either will work, but by preference, I would use Gamma Knife.
And I'd add to that, obviously, we're the converted because we use the Gamma Knife. But it was invented by John Adler, the CyberKnife. And the point was, we looked at stereotaxy and stereotactic radiosurgery at the beginning. You may hear some of your friends have had stereotactic radiotherapy to their prostate or to their liver. And his raison d'etre for the CyberKnife was taking this very focused, specific treatment which injured very little adjacent tissue and moving it outside of the head into other body parts. And to do that, you had to have a slightly different system because you're breathing, your intestines are moving, whereas in the head, it's all very static. So the CyberKnife is a fantastic platform if you're treating outside the head. And as Lewis said, if you're going to buy a platform, you've got a whole load of oncological diagnoses, then that's probably the one to go for. But intracranially, the Gamma Knife, I would say, competes better against the CyberKnife with less CT exposure. If I can ask Aneeta to take this question on. The charity helps reassure patients who are scared when diagnosed. Is surgery intervention enough, or is further support necessary for well-being of patients?
Well, I think that's essential. I have just completed with the charity a survey, probably the largest in the country, of 570 patients that have got trigeminal neuralgia. And the biggest thing they talk about is the terror they have when they have the initial diagnosis, not being heard, not understanding when they're coming to see yourselves. And you've been really clear this evening, but when you're terrified and you've just looked at Dr. Google, knowing that you can come to the charity and there'll be someone that's probably gone through it. So what we have is a patient panel. So we have patients that have had Gamma Knife. These are generally patients that have had a successful encounter with all of these, MVD, whatever it is surgery they've had, and they can speak to someone about what that was like and what it's like on the other side, and hopefully how well they're doing on it. So we try and sell a really positive story, but we're also incredibly upfront about what the journey may look like. And the big thing patients are talking about are the waiting times. That's, the really big. Now, some patients are waiting three years now, and I think it's only going to increase unless they can go privately.
I'd add to that, if I may, that it's not infrequently I'll see someone who's had successful treatment, but as Aneeta says, there's the pain and then there's the fear of the pain, and the fear of the pain doesn't go with a successful treatment. And I've seen people who are very reluctant to stop their medication because they're not ready yet to believe that the pain might be gone.
I mean, to be honest, Lewis, it's a form of post-traumatic stress disorder, because you think, well, actually the pain isn't there at this minute, but I don't know when it's going to come back and attack me. And that's how people are describing it. They're being attacked. Their face is attacking them.
Yeah.
Thank you. So I'd probably direct this one to Dr. Yates. What's the single most important misunderstanding about the trigeminal neuralgia you encounter in clinical practice?
I think it's medicines not being used at high enough doses. A trial of carbamazepine at 200 twice a day isn't going to do anything for anyone. and people will quite rapidly move through 2 or 3 things and find nothing works, or be told nothing's going to work, and then it ends in despair, where in fact these medicines used at high doses are very frequently helpful to people if only clinicians would reassure patients that pursuing them is worthwhile, which it usually is.
Thank you. How do you manage patients who relapse after initially responding well to gamma knife? So we can repeat. If you've had less than 6 months, we're a bit pessimistic that you'll be a true responder, so we may direct you to another treatment. If you've had more than 6 months or a year of benefit, or indeed a lot more than that, we would certainly consider you for retreatment. Something that may put us off is if you have developed a lot of dense numbness from any of your either percutaneous radiofrequency treatments or gamma knife treatments in the past. Because each time you lesion or injure the nerve, you're potentially increasing the risk that you'll get that painful facial numbness, the anesthesia dolorosa. And that is something that's very difficult to treat, and patients say it's worse than the neuralgia. So first time round, although it's a couple of % risk, that goes up each time you treat. If you've had gamma knife, it doesn't stop you having other treatments. So if someone really didn't want to have microvascular decompression and they were a candidate at the beginning and they had gamma knife that worked for a while, then it recurred, they've still got the options of all the other treatments as well as gamma knife. So you can still have a microvascular decompression after that. Same thing, anyone wants to add anything to that, or should we go on to the next question?
No, I think that sums it up perfectly. Other than to say, as I mentioned before, that it's not unusual for someone to have recurrence after one of these procedures, but quite often it's not as bad as first time round, and they're perhaps more likely to get decent analgesia with acceptable side effects than they were when they first presented. So it's always worth re-exploring the medical options as well as looking at the other surgical options.
That's very helpful. Okay, next question. What's your treatment for anesthesia dolorosa if it happens after gamma knife or surgery? Should we start with Tim? That's usually where they first go for help.
Indeed. Well, I think it's very important to make sure you're sure about the diagnosis and that they haven't, in fact, been treated inappropriately for something that's been trigeminal neuropathy the whole time and that may simply have worsened. And so one does resort to some of the same medicines tried for the paroxysms of pain, despite the anesthesia dolorosa being continuous. You might use agents that are more commonly used for neuropathic pain elsewhere, higher up in the list, like duloxetine or pregabalin or gabapentin, but it's very unusual that you make very much headway with this. And so we try some simple cutaneous treatments, and then I ask the neurosurgeons for help.
Yeah, it's very difficult, and I'm glad to say it's something I've only very rarely had to encounter. And for someone suffering neuralgia, it seems impossible to believe there's something worse, and will often say they'd happily take any risk, but sadly it's true, there really is something worse, and it's sadly also that's in our gift. So we manage as best we can medically, and we've had some success recently by doing what's described as functional neurosurgery, which are operations to alter function of the brain and procedures done to alter people's perception of pain, which is having some benefit, but it's probably a bit early to describe that as a standard treatment.
Thank you. I've been asked by the panels to wrap up, and there's been a burst of questions. So I'm just going to answer probably the easiest and quickest one from Ashfana Rahman. Can younger patients benefit? Yes, absolutely. Younger patients can benefit from gamma knife. We're just a bit more wary, because if you have another 80, 90 years to live and you get recurrences in the future, your lesioning procedure incidence will go up. And the more lesions you have, the more the risk is that you'll develop numbness or painful facial numbness over your lifetime. So we try to direct people to microvascular decompression if they're young, if that's possible. I'd like to say thank you very much for the faculty. for taking your time out this evening. Thank you very much to Amethyst for hosting us so professionally. And thank you for everyone who's tuned in. For those whose questions weren't answered, they will be addressed in writing later. And remember to look for this on the Amethyst YouTube channel. Good night.